Gary's going to lead a conversation with two resident physicians, one family medicine, one internal medicine, who are going to share their views and their opinions about what they hope the primary care system becomes and what type of system that they are hoping to practice in the future. So Gary, please come up and invite your panel to come up and introduce themselves. Thank you all very much.
So welcome everybody. I'm Gary Jacobs from VillageMD. I'm the Executive Director of the VillageMD Center for Public Policy, and that's a whole discussion in itself why we have that. But moving primary care forward, moving the model we believe in forward requires a lot of work in Washington, and that's what I get to do. So I'm very privileged to be able to do this kind of work. I appreciate it. And it means that I'm on Capitol Hill all the time. I'm within the administration all the time, really trying to teach people what is really happening in the real world and how it applies to decisions they are making. With that in mind, we have a really interesting opportunity to have a little panel discussion today on the future of primary care. And my job as moderator is to not only make this interesting, but make it exciting from the perspective of we are very positive on where we're going as a field, why residents are jumping into it or jumping out of it. We need to know that information. And we're very lucky in Washington, D.C. We have some wonderful academic environments for teaching. And I have two great people to talk to you about this today with me. So Kevin, maybe you want to introduce yourself first? Kevin Chung.
Working? Oh, there we go. Hi, I'm Kevin Chung. I am PGY3 at George Washington University, internal medicine in the primary care track. I'm from Seattle, Washington, went to University of Washington School of Medicine. I have an interest in addiction medicine, health equity, anti-racism work in medicine. And I am going to be doing a chief resident year at GW as an ambulatory chief, and following that I plan on practicing primary care.
And Diana?
Yep. Good morning, everyone. Diana Rubio, third year family medicine resident at Georgetown University, affiliated with MedStar and Washington Hospital Center. I am a Maryland native, and I also went to the University of Minnesota for medical school, so go Gophers. After residency, I plan to go into health policy research as the incoming Robert Graham Center Fellow, so I'm really excited about doing that work and staying in Washington.
Well, that's great. So let's kind of set the table by looking at the environment for a second, and a lot of movement towards value-based care. Organizations like mine thrive in that environment. We move away from the payment of traditional fee-for-service to taking total cost of care risk and understanding what that means within creating primary care teams to be the linchpin to the healthcare system. And the teams are evolving, as you heard in the last conversation, quickly and rapidly. So my first line of questions would be around the politics of residency programs. And we always talk on a policy level. We don't have enough primary care providers, and we have to come up with ways to get more primary care providers. And it starts in medical schools. And the dynamic of primary care versus especially resident programs. Could we talk a little about that and give a perspective from both of you?
Sounds good. Thanks. That's a great question. I think nowadays it's hard to be a primary care doctor, and so a lot of thought goes into picking your specialty and also thinking about what kind of primary care you'll provide your community. And so for me, I will say in residency, I came in post-Dobbs decision, right? And so that affected where I wanted to practice, where I was going to apply. And you can see that, applications for residency programs in states with abortion bans decreased. You can also see, let's say, in terms of I don't know, like most recently, the SCOTUS decision on race and admissions also has a lot to say in terms of recruitment of residents into our programs and how will we be able to provide primary care doctors to those underserved areas. And so I would say those are two big ones.
Thanks, Jen.
Yeah, I think as a millennial doctor, I think we all, like, our generation grows up in like a movement, like we're all like aware of politics and advocacy, and most of my colleagues in medical school and residency have an interest, at least a part interest in like advocacy for our patients, for us. Actually, I was part of helping form our residency union at GW, and we're in the midst of negotiations right now. So I think it's just kind of weaved in throughout the culture nowadays. I think it's program dependent too, but also at GW we have a wonderful health policy elective that's very robust, and we get to meet with folks on the Hill. We get to meet people in DC, especially in a program in DC where we're so close to where things happen. We get to kind of be more plugged in and get some more insight into the politics of medicine and healthcare delivery. And so just being here helps us kind of be exposed to that and become more passionate about it.
Can you talk a little about numbers of slots available in specialties and then primary care? Is from both of your experiences, is the fighting for more residency slots an issue, or how do you resolve that, and how do you lobby to get more? How does that work internally to your environments?
Yeah, I think in internal medicine, it's a little bit different in family medicine too, because we have so many subspecialties and fellowships that most people who go into internal medicine in academic programs tend to go into specialties. I think less of it, I don't know like all the data, but my impression is that it's less of how many open slots there are, but more of how do we drive interest for people who have options to go into anything they want to stay with and stay in primary care.
Yeah, so just going off of what Kevin said, for family medicine in particular, there are a little under 800 programs, residency programs in the country, and every year we have a little over 5,000 residency slots for the country, right? So if you're thinking about it that way, there's already a primary care physician shortage, and so thinking about, well, for the entire country, you're only going to push out 5,000 doctors in primary care in family medicine alone, not including internal medicine, obstetrics, or pediatrics. But thinking about it that way, it is a huge problem. There still needs to be a push from federal legislation to increase the GME slots for us in primary care if we're really going to be serious about fixing that shortage.
So if I'm do the schools want to focus on getting more specific type of residents versus other residents? And where's primary care fit into that whole picture? Are you getting more status nowadays because we're doing all this wonderful work in Washington, hopefully having some level of impact? Are you noticing that or not really?
I think it depends. I think it really depends on what part of the country you are in the U.S., right? So for me, when I was doing my medical training in the Midwest, family medicine was well-regarded, well-respected. And so that was a great place to train. Coming to DC, it is more a bit of a more specialty-focused area, and so primary care seems to go into the background, even though we are the backbone of primary care. So I think there's a little bit more work when it's coming to culture change on the East Coast.
Yeah, I think I've seen that too. It coming from Seattle, we're actually dual applied FMIM because like family medicine is such a strong presence in Seattle and Washington and the West Coast, and it's very well respected, and it's just in the conversation. Although I still remember a surgery attending who asked me why when I asked why I said I want to do primary care. But I think here too, while there is more specialty focus, I do notice just the rhetoric around primary care is a lot more respectful. People who are going into specialty say like, I could never do that. People are starting to appreciate the challenge in primary care and that it does take a lot of work to be a good primary care doctor. And so I think that has shifted a bit.
I know living in Alexandria, it's pretty difficult in Northern Virginia to find a primary care physician or a team. And we chose, my wife and I, a concierge approach. And I found that a lot of what I had to do initially was help educate my doc on, like, from a consumer perspective, what my expectations are. And she was open to it. And now we're exploring integrated medicine together, and I'm helping her kind of find a path there. So I think that as long as you remain open and listen to patients, it helps in understand in building the team and the responsibilities of the patient, the providers, et cetera, right? But we can go on that for a while, but we can't right now. So let's move to another area that's very important to the Biden administration and Biden-Harris administration and being talked about a lot, health equity within primary care, within healthcare in general. How is that interwoven into the residency? Is it in the syllabus, is it in the programs? Can you talk a little about how we're bringing more people from different backgrounds into primary care? An example from my perspective would be that we participated in a program called ACO REACH. It's a big value-based initiative in the CMMI models. And there's a health equity component where we get a little more revenue for treating people in underserved communities theoretically. And it's supposedly to incentivize us to go into those communities. But the biggest challenge that we have found as an organization is you want to have practitioners in those communities that reflect the people they're taking care of, right? Because if you can't speak the language or if you don't look like me, the patients don't necessarily respond. So talk a little about health equity in the residency programs and where do you think it's going and what can we do to improve it?
I think, it's at least in our, I think it's very program dependent. Like the culture of the program at our program, health equity is kind of weaved throughout the fabric of our, like our didactics. I mean, just the patient population we take care of, we have to know about it and talk about it. Health disparities and inequities like affect every one of our patients who comes through our doors. And so I do think, talking about health equity is kind of like a requirement of our program in each lecture. So it is, I think it's just, and I think it is like a generational change too, but I think overall in my medical school too, it's just a more recognized aspect of medicine that we have to consider with every patient. And in regards to like representation in medicine too, which is super important, I think a lot of this is really dependent on the programs and how they're choosing their residents and the priorities they have and who they're selecting to rank. Because just looking at the faces of program to program as I was applying, the classes look completely different just by, where they come from and everything. So I think it has to be a value from the program itself to start making a difference and bringing more representation.
Yeah, I echo that, Kevin. As the first doctor in my family and as someone who comes from a disadvantaged background, it's really important for us to be reflected in the community and be reflected in the profession. There goes a lot when I have patients from similar backgrounds and, we start chatting it up, we start connecting, and they feel like they can trust their doctor a lot more because they know where they come from. They know the hardships that they've endured with their family. And so if we have more of that in family medicine and primary care, if patients could connect with their doctors, I think that'll go a long way in making our communities a lot healthier. With regards to our residency program, love family medicine because health equity is such at the forefront of our specialty, and especially at Georgetown, we do have a Center for Health Equity, which is having a lot of movement right now in terms of projects and research to help elevate the health of our communities. We have didactics, as Kevin also mentioned. We have quality improvement projects aimed at health equity. We have different tracks to help us learn more about health equity and how that affects the communities that we're currently servicing. So lots of work there.
It's evolving quickly, though, right? Because we're getting patient satisfaction is a big indicator of shared savings and bonus programs that people are developing all the time right now. And if you're not satisfied in every way with the visit from a patient perspective, you get dinged as a provider. And that's a whole other part of this discussion too. But it's pretty germane, right? That if you're putting somebody in Phoenix, Arizona, who doesn't speak the language of the people that live in that clinic area, it's going to be problematic in general, right? And when you have a shortage, that makes it even worse. So the innovations are around bringing in people to help facilitate dialogue and conversation, and that also broadens the team. So team-based primary care, home-based primary care are models and concepts that are moving, in my opinion, at lightning speed now, because we really need to figure out how to really be relevant to the people we're taking care of. And
Right, and it's not only the language, it's the culture, understanding the culture of our patients, and how to connect with them and provide the care that makes sense within the bounds of their culture. And like you said, team-based approaches is huge right now in primary care. At our residency clinic currently, we have help with wraparound services, so social work, patient navigators, prenatal navigators, helping us provide wraparound services and provide those assessments to our patients so that we can provide more comprehensive care.
oh, that's great.
Yeah. I also want to add that, as someone I plan on working in like a federally qualified health center, like a safety net setting, and as someone who comes from a very privileged background, I think and as so many of people going into medicine do, I think it's really important that education is there about like cultural humility and, and understanding the social determinants of health that, kind of form the background of the patients who are walking into our doors. And so like when I see my patients, I actually am I'm very upfront. I talk about things like racism and like health disparities if it's affecting the things they come up with. And I find that actually helps me connect better and they feel a lot more seen. If I'm very frank about those things, that they have a doctor who understands that these are things that affect their daily lives. Yeah.
That really warms my heart hearing that, because it's one thing to talk about it, it's another thing to do it, right, and be in it. And that's great that you guys are being exposed now, and we'll bring it to your practices as you move on. So let's move. Can we always talk about this issue in the policy world too, reimbursement and fee-for-service being the dominant form of reimbursement, and now moving rapidly to whatever your definition of value-based care might be, or outcomes-based reimbursement is easier. Because in my world, when you go to Capitol Hill, you really got to speak in a way that people understand what you're talking about. And when I run around talking about value-based care, some people get it and they understand where you're going with this, but it's really like reimbursement that's tied to outcomes and measures, right? And that the quality is why you're getting reimbursed in that way, and the patient satisfaction. Do you learn about this in school? Do you learn about this in residencies? Are your institutions ingraining it in your education so that you can like walk into the real world and say, oh, I'm not just a fee-for-service doc. I totally get it. I understand how to manage risk of a population, and that might be called population health as well. But how do you learn about that?
For us, For me, I guess I will say it started with lived experiences, and then also in medical school, when you do have your intro to healthcare systems, you learn about the different payment models within healthcare and how that affects patient outcomes. And then going into residency, of course, you learn on the job because you are also doing your billing. And so you learn about the G codes, you learn about the preventive codes and what that means in terms of reimbursement, Medicare codes, and such.
Yeah, I think, yeah, we definitely, it's part of like medical school curriculum, just the high level overview of different types of like value-based care, capitation models, fee for service, all those words that I kind of understand. I think, and then it's there if you want to like learn more about it, there's opportunities to find it. And I think it's really dependent in terms of practice on your resident clinic, how much experience you get learning how to practice like population health or value-based care kind of approaches. Our clinic, it's a fee-for-service clinic, but we also have a Medicare ACO patient population. And so we are taught like panel management, we like how to like open Epic and whatever, slice or dice or whatever, and find out like what % of your patients are meeting this metric. You know, kind of the bird's eye view, which is like kind of more approaching the quality-based metrics. And so that's been helpful. Yes, I think it's probably dependent on like what kind of system you practice into.
Yeah, and CMS just adopted a new G code to help with reimbursement for longitudinal care in primary medicine, and also Kevin mentioned doing more social determinants of health screening and talking to patients about that, and so there also is a code for that as well.
So know that to get that 2211 code, that takes a lot of work, and that's a lot of lobbying to get there. But it was a really nice day when that actually was going to happen. So that's great that you guys can get that, appreciate it, and put it into practice like right away. So in your residencies now, you actually are accountable for billings. So do you get taught that? How do you learn about that?
Yeah, so in the outpatient setting, we do the billing for every patient encounter that we do. And so when we're an intern, we get didactics on billing, coding, what that means, and really how to put in the diagnosis codes that make the most sense for your patient and what you do for them.
Yeah, I think it's a lot of it's on the job. Like, hey, was this a 3 or a 4 or a 5? Just with your attending on a case-by-case basis, and then we get like a little bit of formal didactics.
Yeah, and it's interesting because as a resident, we're salaried. It really doesn't matter for us in terms of the money that we get, but it does help to know what that means on a broader scale for the healthcare system.
So as long as we're at the broader scale and we're, in the last part of our discussion here, let's talk about a vision going forward and like what can we do to set the table for the future of these programs? Because we recognize, in the world I live in, primary care is the place where everybody has a primary care doc. This is a great state, right? What I'm going to define here. But everybody has a primary care doc. The primary care doc is part of a team. We have mental health. We have pharmacy. We have social determinant, local people, navigators, helping people. We do home-based primary care to get people who can't get out of their houses or have mental health issues and can't leave their houses, or have no transportation or aren't eating and they need meals delivered to their house. So when you think about all of that activity, that excites me about primary care. I love talking about that, and I love educating people about what we do so that that whole sense of what primary care as a reinvented form of family care, what it looks like. And so is that what drives a lot of motivation for people jumping into programs? Are they thinking that? Or are they just, what's the mindset of going into a primary care residency for most people that you interact with? Maybe that's where we start.
Like why people choose to go into primary care, what makes them excited about it.
Did their dad do it or something before, and they're following the chain, or is it? This is the way I just described it and I was moderating my enthusiasm there. But if I was really excited, I think I could sell that all day long. But how are people doing that?
Yeah, I think, well, I mean, I think some people go away from primary care if they have parents who are in primary care.
Okay.
But it probably depends on what their parents' practice are like. But yeah, I think, most of us who choose primary care go into it because we've experienced like the reward of primary care, the relationships you build with patients, the continuity, the incremental change over time, which is so hard to get at medical school, and still hard to get in residency. But I kind of knew that going in, and I still, I went into med school wanting to do primary care, and so I already kind of saw that as a reward. But people who are there are like excited about the continuity, the relationship building, and the impact on community health you can have for making more health equity-minded folks. I also think that exciting models of care, like these value-based care clinics and stuff like that, are also enticing because they seem to kind of solve a lot of the issues with primary care right now in terms of burnout. I think our generation is a lot more focused on work-life balance and that our life isn't just medicine. We have life outside of medicine. And so I think that is helping. But I think the big question is how do we generate more excitement for the things that are rewarding about primary care? And it's hard to do that in medical school, but I think things can be done. My school, University of Washington, did a good job of it. And in residency, like our primary care track, we spend a year in clinic straight, where you really get to experience the joys of primary care and be a primary care doctor, as opposed to more fragmented continuity clinics. And everyone who's gone through that or done a little chunk of time always comes out of it wow, this is a lot more enjoyable and exciting than I thought it would be.
Same.
Yeah, likewise. I think the biggest draw to family medicine is the continuity, the longitudinal relationships that you build with your community, being able to see that change that you can make in the community in general, I think, is pretty powerful and is a big draw to primary care. It's one of the big reasons that I went into primary care, making sure that I was at the forefront when it comes to my community and advocating for them. And in medical school, I think a big draw to primary care is also doing the longitudinal integrated clerkships, which can help medical students appreciate longitudinal care and what that looks like, and what a career in primary medicine also looks like as well.
So to do what we've just talked about in team-based primary care, there are components, like we said, mental health integration, pharmacy integration at some level, social determinants, all cost money, and there's not necessarily codes for that, right? So to really play in value-based care, the practice needs money to create analytic capability so you can walk in real time and see what a patient's current situation is. You can use a care manager to manage the day-to-day when you're not available or you're not there for them. They have somebody managing them, scheduling visits for them. We've clearly documented that the more primary care visits a chronic person with multiple chronic conditions has, the less likelihood they are of readmitting to hospitals and not having ER visits. They call their doctors generally first. So that all is working for us in general. But it comes down to if you're in a local community and you're trying to figure out, do I stay in fee-for-service or do I move to value-based care? How do I integrate the two in my practice? And it's a small, let's say it's a two-person practice. And it's suburban, rural, urban, wherever it might be. It's really expensive to integrate these new programs. So there has sprung up this whole cadre of organizations that help facilitate that transformation and have systems, and we talk about them every day. So they're there, but that costs a lot of money to execute and implement, right? The sources of money when it comes to primary care seems to be either the local hospitals buying practices or these new innovators, disruptors, whatever the jargon of the day is. And I feel like we're in that space. I find it terribly exciting because the innovations are really moving the ball forward in advancing everything we're talking about. But it does cost a lot of money. And same vein, there is a dialogue going on in Congress around the role of private investment in healthcare in general, and then in primary care where there's been a lot of private investment. I have a lot of feelings on this subject. Do you guys have a sense that you wanted to talk about a little bit on this? I think it's a good topic for us.
Yeah, absolutely. I'm very wary of, I mean, we live for better or for worse in like a capitalist system, and I worry about a little bit about how I think we need to be careful about how we implement value-based care in these new systems, these innovative systems, in a realm where there is a lot of like private equity and for-profit businesses investing into these systems. I know already that even well-meaning, reimbursement strategies or quality, in terms of quality, can have unintended consequences. We have to be careful that we don't leave out patients who are uninsured or underinsured, or patients who are more sick and maybe make metrics look worse. I see every day working in a for-profit hospital and taking in patients, admitting patients from for-profit nursing homes, like the negative outcomes that can happen when there's so much focus on profits without enough regulations or the appropriate quality metrics and whatever, those things. And even things like, we want to reduce CLABSIs in hospitals and reimburse for that. That's like a good thing, right? But, some hospitals may end up doing practices that harm patients in order to reduce those numbers. So I think we just have to be careful. I think value-based care and all this like investment and innovation going into these models of care is exciting, but we have to be wary. We have to always remember prioritizing the patient first, and patient care first, and not just profits. And then how does like Medicare and like the bigger systems, motivate or drive that to happen, so we don't kind of lose people or cause worse health outcomes.
If you guys had a chance tomorrow, Liz Fowler from CMMI will be here, and that's her principal responsibility, is using the authority of CMMI, which is the Centers for Medicare and Medicaid Innovation, to spark a lot of what we're talking about, to drive people to value. Because Liz is out there saying by 2030, most Medicare beneficiaries will be in accountable care relationships at some level. And we're all on that path to trying to figure that out. Not for the faint of heart, mind you, but trying to figure it out. By the way, in that idea of being skeptical and being cautious and watching who's putting money to use and how it works with your practices, would you say that community hospitals act very similarly to other entities that are investing in these kind of things when it comes to like your life in does it matter? Is a nonprofit hospital, like there was a movie documentary about Pittsburgh recently, Inhospitable, I think it's called, and it really talks about there's always a battle in Pittsburgh with UPMC and Highmark, and now they're both providers and payers, and people get very confused in the community. Are you really doing community good? Talk about it because you're both nonprofit. So blurry lines between profit, nonprofit, all of that going forward. I think a healthy skepticism is a good idea, but we still have to move the ball forward, and it does cost a lot of money to do these things. And where primary care has got to get to, we got to get over that hill first, and we're not there yet, I don't believe. but I didn't let you finish. I'm sorry, Diane. Go ahead.
I agree with Kevin. I do think that we need to be skeptical about, venture capitalists and private equity coming into the healthcare space. They're already here. They're already changing primary care. So I think it's really important for us clinicians to get into that conversation to make it more of a collaborative approach. Because I don't know, you already mentioned Gen X is a little different than Gen Z and millennials. And so burnout is a really big thing in primary care, especially with the shortage that's only going to climb. And so taking care of our well-being and taking care of this burnout, I think are going to be big priorities for our generation. How we fix that is up to us.
Agree, and talk about a little about work-life balance to that point, so that it's fun. I could remember being in your seat. Feels like yesterday, but it's not. That's what happens as you get older quick. It just, you wake up and you go, whoa. Anyway, you're there. How do you change? How do you find the work-life balance scenario that you don't live your work and you don't, or do you work to live? I mean, how do you talk about that a little bit, if you could?
Yeah, I think going into medicine, we knew that it was going to be a hard road. It was going to be a lot of work. And as a medical student, you do get that perspective because you do shadow the residents, you do shadow your attendings, you get that mentorship. As a resident, the tables kind of turn, right? Because you are expected to be a doctor all the time, right? You're always on call, you're always taking a 24-hour shift, working night call, being post-call. So your schedule really isn't your own as a resident, and I think that is unique for us as our first job outside of medicine or in medicine. So it does take a lot of reflection in how to be well in residency, and it does take a lot of support. And so I think a lot of residencies understand that and are making some more guardrails for us so that we don't burn out and we feel well while on the job.
Yeah, I think, resident unions are a big thing, and there's a big movement across the country, and I think that's driven out of a desire for wellness and to avoid burnout and just to advocate for ourselves more. I do think burnout and mental health in medicine is so important to continue talking about. I recently lost a friend and a co-resident in our program who died by suicide this year. And so it's so important to make sure that we're thinking about that all the time. I think a benefit of going to primary care, which is a fairly non-competitive specialty, is that it's a lot more, there's less pressure in medical school to get the highest board scores. In residency, I have friends who are going to GI and cardiology who are just spending all their free time pumping out publications, just working on research. They're I have this meeting with this research advisor, and I'm I'm just gonna go hang out with my cat. And so it's just, I think that should be focused more too. If you want to have a good work-life balance, you can get that in primary care. Even beginning in med school, you don't have to gun as hard as your co-students or co-residents.
We have a practice in Bend, Oregon, and it seems to be the happiest group of docs I get to interact with because they have figured out that they moved to Bend for a particular reason. They love the environment they're in. They love the outdoors. They, I could call up on a Tuesday and, oh, John's not here today. He's whitewater rafting. And it's okay to have that conversation. When I compared them to our large multi-specialty practice in New Jersey, they don't get to do that as much because I think they create their own pressures with each other, right, in groups. But primary care-led teams is our vision of integrating specialists with primary care, and everybody's equal at the table. You're there longitudinally for the long period of time, whatever that might be. And as Kevin, you and I talked a little about, one of my experiences at George Washington, and there's nothing to do with the particular school, it just happens to be where I happen to be. I I loved my PCP, and they encouraged me that since I was using a couple of specialists when I had a particular incident, they encouraged me to have a PCP from there too. So I did, and I loved him. My wife loved him. We both thought that was the best. But then they rotate out really quickly, right? That's a problem. How do you deal with that kind of thing? So I think an academic environment may not be, it's not where you settle in maybe for your primary care unless people commit to it and stay for the long term. Don't know if they can do that so fast because there are lots of options that they get faced with, right? And choices you get to make.
Yeah.
Do you guys have a sense of where you're going to go in your practice? Not like where you're going to live, but what type of practice you want to go towards now and what it might look like 5 years from now?
I mean, I'm a primary care doc. I love having my hands in a little bit of everything, and I think academics is the great place for me just to be able to do that. So I think that's what I'm going to be doing in the next 5 years.
Yeah, I do want to work in a federally qualified health center in an urban setting, preferably in my hometown in Seattle. There's a few clinics I've been at that I love. But I think ideally, I do love teaching. I do love, kind of passing on the values that we have to the next generation of doctors. And so ideally, dream job, like a FQHC that's also academic affiliated that seats medical students or residents.
That's great. Okay, we're at wrap-up time, so I thank you guys for taking your time out of your busy day to do this with us. We really need to be educated to what's going on from your lens because we make a lot of assumptions about the future, and you are the future here. So thank you for sharing that with us. And you have a last comment you want to make at all? I mean, this is a great venue for you to remember 5 years from now, 10 years from now.
I'm just really excited to be here and to be able to talk with y'all and share my perspective. I think if I could pick anything for primary care to grow, I would love to see more initiatives to enhance diversity in the workforce and also to enhance those GME slots for primary care.
Yeah. Thank you so much for having us, humble residents. I think I just want more and more students and residents to experience the joys of primary care. I love my patients, and it makes me sad that so many people don't get to experience that before they go off into their subspecialties. So I think it's so important to focus on improving the experience in training around primary care to make people more motivated to join.
I just thought of the last thing that I wanted to just ask you about. You have a point of view on the role of nurse practitioners, physician assistants, and to what extent they should be independent. Do you have a feeling about that?
I think they're I think they're so important as part of a team-based practice. I do think that we want to make sure that the quality of training is regardless of what path you take into providing medicine, is strong because medicine is complicated. You have patients' lives in your hands. You're prescribing potentially dangerous medications all the time. And so as long as we have a robust training system and checks and balances, and we know that, and whether there is supervision, I think every one of us should make sure that we're practicing good medicine, regardless of how we're doing that.
Maybe that'll be one of my research topics as a fellow, looking into that. Thanks for the idea.
It's a good topic, though. Yeah, thanks. It's interesting because some states full scope of practice, some states not. So a lot of politics in playing that out, but when you have shortages, you got to deal with that.